here. So it's my great privilege actually to introduce Dr. Ranjan Shetty, sir. He needs no introduction, and I think in India has done pioneering work in structural, especially, and I was fortunate to see him at work in his own center. And so it gives me great pleasure to announce Dr. Ranjan Shetty. He will be speaking on Mitra clip implantation. So we know it's an exciting new therapy, not exactly new now. So we have 5-year results of COAP now, and we hope we'll be able to learn a lot about Mitra clip implantation tips and tricks, and a little bit about indications. So over to you, Ranjan sir. Thank you so
Yes.
much. Yeah.
Thank you, Saujatya, for such a wonderful, introduction, and always happy to be part of this. I've been actually missing some of this meeting. It's so good to see all of you. I hope I will attend more of these. So now today, we thought we'll discuss about Mitra clip implantation, little bit about evidence and the trial, followed by the technique. As we discussed that all technique or any procedure, when we do, it's divided into multiple small technique, and it's important for us as interventionists to probably split it, understand each part, and then probably do it. What I also want our panelists and moderator to do is just stop me whenever you want. It's a small group. I think it's more important that we just stop me and discuss rather than having a complete discussion at the end. We could do it at any point. Thank you once again. So, trials of mitral, as as it was already told, it's no longer a new therapy. I think the first implant was done way back in early 200, 202, 208. That's when the trial came. Yes, the interest is now more because it's approved in India, but it's been FDA approved for some time, like something like 2013, 14. It was FDA approved. And the best part, indications are obviously limited. It's not for all MR, it's not for all age. We need to select our patients right. And we should also give them probably a realistic expectation. And it's very expensive. That's where it has been, the cost is the one which has been quite high. I feel the best part of this therapy, this I'm trying to tell you even before we start, is the safety. Compared to many other structural intervention, it's quite safe. Chance of us messing up on table or, because the clips are small, the procedure is okay. It gives you a lot of time. Unlike say TAVI, where the time is of importance and it's sometimes it's ARIA part, the complications happen at any point and it's very risky. Whereas here, when in doubt, you could just wait, have a cup of tea, come back, maybe talk to people if you have doubt, and then finish. Now let's go to some of the trial which we know. One is the Everest trial, which was the first of its study, which spoke about edge-to-edge repair, which was initially for feasibility. Everest 2 confirmed the safety and efficacy to people where it compared to surgical repair, and COP trial, which was done for secondary MR. Now, all of us know MR when it's a complex thing. Unlike AS, it's very simple. The anatomy is simple, structure is simple. So, TAVI has been there for a long time. It's becoming extremely popular. I think every month now there are more than 200, 250 implants of TAVI which happens. And countries like Germany probably do up to 40,000 implant a year. But when it comes to Mitra clip, the anatomy is extremely complex and it's always a apparatus. We don't talk about mitral valve, mitral disease. We talk about mitral apparatus. That means MR etiology is multiple, unlike AS and AR. So when these trials came, when this clip came, it is which group of MR is it suitable? Now there are two MRs which we talk and highlight. One is the primary MR. That means MR because of the valve. And in elderly, that's where the Everest trials took place. It was a primary MR elderly, which actually told who are, there was a high surgical risk where Mitra clip was approved. The first approval came for a primary MR, more like a valve-related MR, a degenerative MR, which is considered twice as common as AS, especially in Western population and aging population. The second was the COP trial, which is secondary MR, where it is the dilated annulus. There's no surgical indication here. Normally, a normal coronary dilated MR, you don't offer them surgery, right? You manage them conservatively, and that is where the Mitra clip again is beneficial. So these are the two subgroups where Mitra clip is being tried and used. Initial indication came for the primary. Now, this is Everest 2 trial, which was published this was a randomized trial which actually compared percutaneous repair or surgery for mitral MR, and some of these names are familiar to you here. So it's edge-to-edge mitral repair, just like the Alferi stitch which the surgeons put. Surgeons themselves don't like the Alferi strip, so it was surprising for them that the Mitra clip, which it utilizes a similar technique, was actually useful. So what this showed is, in this trial, which to head-to-head comparison, the efficacy of the Mitra clip was less than the surgery, but safety, it was safer. This is the key. This is something which will keep coming back. You may not be able to make MR zero, but it's quite safe to do a Mitra clip. And overall outcome, which was basically free from grade 3-4 MR at 12 months and the safety endpoint at 30 days, was better. It has a superior safety but inferior efficacy. And here it was 279 patients who were randomized into 2:1 ratio. So just to tell you, Everest 2, 184 patients were in Mitra clip, 95 underwent a surgical repair or replacement. These are classically older patients. In this trial, the age was comparable, but here it is done for a mean age was 67. Adverse effect was much lesser in Mitra clip therapy, 9.6 versus 57%. So, the peri-procedural adverse event is much less, and there was freedom from death, and surgery and MR was higher with surgery than Mitra clip. Okay. So efficacy, the surgery was better, whereas uh, safety, clip was better. So, and the result was durable, and there was a very late of conversion into later surgery, but this is a short-term follow-up. The subsequent analysis actually demonstrated the MR reduction improved. There was definitely improvement of NYHA class, and LV dimension also was reduced. But obviously, there is no change on the initial rhythm, and uh, again, it keeps coming back to safety. So this is a meta-analysis of all the trials where it was compared. So if you look at, this was not the randomized, this is just a comparison. Mitra clip in 3,000 odd patient and surgery in 3,000 odd. Again, the one thing which definitely comes out in Mitra clip trials, that it is definitely safer. If you see any outcome, you see the safety outcome, it is much, much better with the Mitra clip. So that's the, I think, carry home message in this trial. Now, there was a Everest high risk registry who had a prohibitively high risk for surgery. Okay, and this included both secondary functional and ischemic MR. So in this patient, there was not mortality benefit, but there was definite benefit in heart failure admission and functional class. So this, again, from Everest trial, what we realize is the longevity may not change, but recurrent admission with the patients with severe MR, is decreased and their functional class is better. Now, COP trial, which assesses the percutaneous for high-risk surgical patient, again, device therapy with secondary MR. This is a specific trial with secondary MR, and this is the, COP investigators. So 16 were, 614 patients were enrolled, 302 were assigned to the device group and 312 to control group, half and half. And what do we see here? Among patients with severe mitral regurgitation who remain symptomatic, that's important. They have to be on maximally tolerated therapy and they have to be symptomatic. If an MR patient says, I'm able to go and do everywhere and do everything, you don't need to do anything, then all-cause mortality was actually reduced than medical therapy. So just to summarize this trial, this is a secondary MR trial. So there is no surgical option here. Nobody offers surgical option. So you are left with maximal medical therapy versus this is a very common subgroup, especially in our Indian population, DCM with MR. You're left with only medical therapy. Surgery for a year less than 30 is anyway prohibitively high, and these don't have primary mitral regurgitation. So this showed that the all-cause mortality and heart failure admission were lower in patient who underwent mitral, percutaneous mitral repair. And this actually led to FDA approval of MitraClip for heart failure with functional MR. As I was telling, initially it was for primary MR, later it is functional MR. And this is how the clip looks. Clips also have gone generational change. The present clip is called GT4, which is much easier to use, less, number of steps are less. Single clip is enough for most of the time. Now, how do we manage? This is a general guideline. So select patient EF less than 35. Surgery is the first option, but reduced EF, severe secondary MR, first try guideline maximum. If the symptom disappear, you don't need to do. If symptom remains in such patient, and especially if their dimension, systolic dimension is less than 70 and PA pressure is less than 70, they do well with transcatheter mitral valve and repeated hospital, this is the wireless monitoring. So basically 2A indication is for severe functional MR with EF between 20 to 50 with not too badly dilated LV. What we know in natural history is once the LV is very, very badly dilated, these therapy also doesn't help. I have one patient now who's in this category who's been refused transplant too because of his the lung. He gets repeatedly admitted, but his LV is extremely dilated. So as we were discussing, the indication for him will be to prevent recurrent admission, but we really don't know how much benefit we can offer. But this is the only therapy which can do some good to him, but it is expensive. So I've been talking to this patient, but there's set up one more patient who is undergoing a renal who's on a dialysis, was more like MR. His LV is not too well dilated. So he becomes a very ideal candidate for this therapy. So this is something which we should do. I'm just going to revise the indication because this is what specifically this was asked of me, to discuss the indication. So it's for select patients. Primary degenerative MR, it's for people with high surgical risk. So elderly, primary MR, not rheumatic. Rheumatic is out of question. If you have a mitral area less than 4, it is out of question. So you should have a little bit dilated LV. Mitral area should be more than 4. That is the first thing. Severe rheumatic MR, however bad, is not a candidate because there is a functional MS which is created by a mitral clip. So that is out. So it's for those, say, primary or degenerative MR, maybe some MVP MRs, maybe some flail leaflet which are very close, but who have high surgical risk. So that is one indication. For secondary MR, it is ideal for people who are symptomatic despite guideline directed therapy, and probably it will work best if your LV is not too grossly dilated. That is LV systolic dimension more than 70. It may not work. Less than that, it would work good. So that's where we are. What are the contraindication? People who cannot tolerate anticoagulation at all during procedure, any endocarditis, rheumatic is a contraindication, and any thrombosis in the path, because you're going to use a big sheath which goes up. Now, there are some technical eligibility criteria. These were patient indication. So there are something called as anatomical eligible criteria. So all these patient, you have to do a pre-transesophageal echo. There is an app which is available called for Mitra Clip. You could go through that, understand what all views are taken. It's not that difficult, but you need a 3D echo and you need a good set of people. So it's a team effort. So luckily here, I have a sonographer and an imaging cardiologist who does a lot of pre-screening, and the coaptation length should be less than 2 millimeter. It should not be too far away. The depth where it should be less than 11 millimeter, and flail gap should be less than 10 millimeter. Flail width should be less than 15 millimeters. So these are the some of the anatomical criteria which we need to follow. Along with that, the area of the mitral valve, the area should be more than 4. Now, this is something which I hope if there is any question in the indication and the anatomical, I can take it now or we can take it later. Feel free to stop me anytime. So mitral clip procedure is divided into 3, 4 steps. This is something which I mean, I've spoken about this in multiple talks earlier. It's important that when you do any complex procedure, you in your mind divide into multiple small steps and try to master each of them in your own way, because you don't need to do, for example, if you're doing a TAVI, I feel 2 important steps are crossing and per close. But these two don't need a TAVI patient. Any AS patient, you can cross and measure the gradient. The wherever you do femoral, you can master the per close and especially pre-closing it. So these two, and maybe a ultrasound guided puncture of the artery. So these steps can be mastered even when you're not doing the actual procedure, so that the your mind could be at rest when you are doing procedure. Here, probably one of the most important step is the transeptal puncture. It has to be transesophageally guided. Then you need to take the whole sheath into the LA, and it's very robotic. There are multiple knobs which are there, and there are probably 3 set. There's something called as a guide. I'll show that picture, which also you can manage. Then there is a steerable catheter, which can be lengthened, which can be shortened, which can be moved. So there are multiple robotic steps which are involved. And then finally you go down, you gas the leaflet, and then see that the MR is reduced. Now let's slowly discuss about the transeptal puncture, which is common to almost all current structural intervention. It has to be transesophageal guided. The needle, like your balloon mitral valve, for BME septal puncture, you have to take the sheath with a dilator here. Just the dilator is not enough. Ideally, the sheath should be present in 12 o'clock. Needle should be advanced and you need to go. Now, the extra thing, where should the puncture be? Now, when we do LAA, puncture is supposed to be posterior inferior. When we do BMV, the puncture is supposed to be at center of PFO, that area. Now here, the additional thing what you need is a depth. You need to have enough depth to manipulate your catheter. So the puncture here should be apart, most of us now know to use a bicable view and a subcostal view, but it's also important to do this 0-degree view and measure the length from from the denting to the valve, and it should be minimum 4. Preferably is 4.5. Now, to do that, there are some things which we should do. So, in a degenerative MI, more than 4 is must. In a functional MR, even 3 is acceptable, but 4 is good. So, if you see here, this is the bicaval view, and ideally, you're coming down from SVC to IVC. If you go more down, it will be an inferior puncture. So, here you have to be at the middle or slightly inferior. Next, you want to be posterior because you don't want to be close to aorta. So from middle to posterior, in these two positions, it looks almost as if, for LA also the position is almost same. At this point, you also go to a 0 degree and start measuring from the from the tenting to the mitral valve. And the measurement is done on LA like the way we have shown it in this picture. So in this case, it is 3.8. For a functional MR, this is acceptable. For a primary MR, you need 4. So you may have to do more, you may have to get little more depth. The only way to do it is clockwise your septal puncture needle, and thereby get more posterior puncture. Go more and more away from aorta. As you go more and more posterior, you might get it. So you are in superior to inferior. Between SVC to IVC, you need to be on middle. And in aortic view, you need to be more posterior. In 0 degree, you have to gain more. So if you get the right length, it is okay. If not, turn it and go more posterior. So this is the case which we did, and we are showing the septal puncture here. So if you see in the upper one is the bicable view, I'm almost in the middle of that, and you can see the tenting. Next, you are seeing the aortic view. Again, you are on the middle, and now we measure the length here. And if the length is appropriate, it is okay. If not, go back to the aortic view and try to go more posterior. Keep it middle because you have to be slightly superior to give more posterior by giving more clockwise, and then measure the depth. That is what we do. Once the transeptal puncture, so it's advised that you spend some time on transeptal puncture. Don't accept the first puncture you get, first position you get. It's important to spend some time because that will save the time later. If you have a wrong puncture, wrong position, you will be struggling a lot to capture the mitral wall later and to have the best. So when it's difficult, sometimes, because you're in an unusual position, it may not be easy to advance a needle. You may have to use the stillet. You may have to use diathermy, which is the cautery, which is touched to the opposite. My favorite is opposite end of a coronary wire. You position it, don't move it at all. Just use the 014 wire, just opposite end, just remove it. Then push the usual end across the broken barrow needle and then enter LM. So that's my favorite. Half the heparin is given and the full heparinization. The prior one step important is the femoral puncture itself. You are going to take a sheath which is almost 24 to 27 French. So have a proper puncture, preferably ultrasound guided, and make a little vertical puncture. More structural intervention, instead of making a big tunnel, try to make a more vertical puncture so that there is less tunnel. You need to use dilator and you need to take, and full heparinization is needed. So this probably is showing the septal puncture going to LA, and this is where we use that. This is the opposite end of the wire which I was trying to show. So in this case, the puncture, it was getting slipped. So we used the opposite end of the wire, made a small hole there, and then I use the normal end of the scion wire, and then on that you can pass. It's not just enough to just puncture with the opposite end. It's important to pass the normal wire, and on this safely you can pass your catheter inside. Now, next is the advancement of the clip. As I told, it is an extremely robotic procedure. First, it has a guide which we need to take, and then there is a guide, there is a sheath, there is a clip. So it comes in this. So it's important to make sure that once you do the septal puncture, what you actually do is you put two Amplanza wire into the PA. PV, pulmonary veins, preferably left superior. So on that, you put two pulmonary vein, two Implantations wire, not one, two. On one of those wires, you take a 4 French pigtail and just park it there in pulmonary vein, which later comes to LA. This will allow you to do a constant monitoring. So this in a femoral part, it is outside the traditional sheath, but the same femoral puncture. So one 4F is put into PV, and this will give, and it's very important to do a dynamic, constant LA pressure monitoring, because once you grasp right, LA pressure dips. Once you grasp wrong, LA pressure increases because the MR increases. So constant LA pressure monitoring is done with the pigtail kept with the same septal puncture. Next, you have to, on the other Implantations wire, you now want to take the guide, which is 24 to 27 French, and which has to be continuous. You need to put continuous saline irrigation, make sure there is absolutely no air, and with like we do for ASD, and then take the whole sheath inside. Now once you are in LA, you take the this is kept in LA, and it's positioned around 1 centimeter beyond the septal puncture. Now this is the outer, this acts like the guide. On this, there is a clip delivery system with a clip which is advanced under fluoroscopy, and that is threaded. So this is the guide which is down, and beyond this guide here, which is kept beyond in LA, you take the clip delivery system with a clip. Now it is once you are there, I'm not going to go through all these steps because it's highly robotic, and as you keep doing it, you will realize how to go forward, how to go backward, and how to turn it. It's highly theoretical if you just talk it on the system. All I can tell you is this is how it looks. Now this is the this is the guide. This much is the guide. You de-air it, and this has a positive negative knob which can flex and deflex. Then this much is the clip delivery system, and it is put on this, it is jammed here. Now this much system becomes fixed, and then this is the clip itself which is delivered through this. So if you realize, there are many places where torquing is possible, movement is possible. You need to learn as we do, what knob produces what system. So this is the steerable guide catheter. Inside the guide is the clip delivery system, which has two components. Plus, there are things to be released here. So next, very important thing is, you are in LA now, and you need to enter LV, and that can be done. That is when 3D echo is needed, and you enter into LV. And once you enter into LV, you have to go perpendicular. You're using two views. One is a long axis view, and other is the something like a modified two-chamber view in T. Your role is limited. Your T operator's role is much more. So it has to be two people. Both of us have to be trained. And then once you catch the grip, the valve, inside that, the gripper, the upper part is called the gripper, there put down, you're assessing, putting a color. You don't need any injection here. So it's sometimes frustrating for a coronary interventionist because you're seeing it for a long time and you're not giving any dye. And at this point, if you grip proper, you'll realize that you have to go in between the MR jet, dissect the MR jet, hold the clips, and realize that the MR is much lesser at this point, and LA pressure is falling. Device manipulation should be very careful. Caudal entanglement must be avoided. So this is edge-to-edge repair. So let me show a case of ours who was an 81-year-old person who came with breathlessness, multiple admission, orthopnea, PND, BP is okay, failure. He had a cardiorenal edema. He was related to our surgeon. We gave him Lasix and dobutamine infusion. Lot of past history. He had a rota guided L6 plasty, AACD. In between, he had a small bowel obstruction, which led to a surgery. Both those times when there was a small bowel obstruction, he had to be put on ECMO and brought back, and intestinal resection was done, and a COVID came out of that. So big history, but in recent past, he was actually coming with recurrent admission and extreme fatigue. So more like MR related. This is his heart. EF is around 30% and 33% pH is 50, and you can see a central MR which is severe, and this is how his LV will appear. Now, what should we do next? Because we have tried all medical therapy for him. So we gave him an option of transcatheter valve repair, the Mitra clip, and this is the dilated LV with the severe MR. So what are the steps? We already discussed: transeptal puncture, advancement of a steerable guide, advancement of the clip, grasping the clip of the leaflet, then release the clip. So this is the septal puncture. Again, just to show you, we are in the middle of, in a bicaval view. In a aortic view, we are again in the middle or posterior, and in fourth chamber, we are also measuring the fourth chamber. Here we found the height we got was 3.5, which is okay for a functional MR, but not okay for a primary MR. Once we do, I told you, you put two wires. Now, once you've done a septal puncture, you put two wires in the pulmonary vein, and in one of those wires, you take a pigtail 4 French to measure the pressure. This is the guide catheter, which is carefully seen under the echo to make sure that it is significantly into LA, but not too much into LA. And inside that is now the clip delivery system, which is going. Clip initially is positioned here. So these are the, there is a knob which is M and L, there is a knob which is A and P, and using that, you can slowly turn it. The clip which is here is now slowly turned into LV, and it's like the BMV. It is positioned there. At this point, we see a T, take a 3D T, and enter. So you can see here the clip which is here, and this is the live 3D T of that patient at that time, telling that the clip is, once you go down, just before entering LV, you open the clip, and with the open clip position perpendicularly into anterior and posterior mitral leaflet, you go down and then position it here and there and grabs. So 2-3 places the 3D is needed. Otherwise, it is more of a 2D procedure. If you see here, the clip is grasped in both the views, and you see the MR is reduced to negligible amount. So you see, this is the clip which is grasped, and MR is now into negligible level. And all this could be done with a single GT4 clip. And there was a significant fall of LA pressure from 27 to 9 mean in this patient. So now the procedure, we could manage this with a single clip, but patient still needs, because it's MR, the LV usually deteriorates by 10 to 15% acutely when you take off MR. So post managing them is very important. Most of the time they need inotropes and diuretic and drugs like levosimendan. But luckily this patient tolerated lack of MR well, and he was ambulant and he was discharged on day 4. And this is how his echo looks post. You see, the LV is not improved much, but there is hardly any MR now, and the pH has come down, and he did well after that. So this was his discharge medication with all the guideline follow-up. Now this is the 5-year outcome of the co-op. So in secondary MR, there was lower hospitalization and for heart failure and lower mortality. So the device group did well from control group. So if I have to, and the guidelines are now, more and more favoring the mitral tab. or MTAR or the Mitra clip, because the freedom from death hospitalization is higher, the quality of life is better, and it's more aggressively used in the Western world because the cost is not a concern there. But I think the key would be EF between 20 to 50 and LV systolic dimension less than 70. And they did well on follow-up. This is one of the positive trial with the reduction of mortality. Definitely the symptom reduce. And as we were discussing, for a secondary MR, there is no other option. And there could be younger patients with secondary MR, and even they would benefit much. So it's important to assess all our DCM patients for MR2, try the maximum therapy, try the best remodeling. If they persist to have MR and symptom, we could offer. For a primary or the valvular MR, I think it is meant for those people who are not suitable for surgery. Unfortunately, in India, we do have a lot of patients, youngsters with dilated cardiomyopathy, with practically normal or minimal coronary artery disease, who are extremely symptomatic. Some of them we offer transplant, but if this MR is a significant pathology, this is a good therapy to offer. Thank you, and I'll be happy to take any questions.
Well, thank you so much, sir, for that elaborate presentation. So I think we can have questions now. And if possible, maybe I could start with one or two observations or maybe comments which I would like. Firstly, sir, like you said, primary MR.
Yeah.
So in primary MR, what do you think is the future? Is Mitra clip versus you see Mitra clip, or do you think that transcatheter mitral valve replacement, like
Yeah,
with a
I think,
MyValve or things like
yeah. There are
that,
two
is
things. I
one?
think there's something called a standine, which is really picking up. That may be a future for a primary MR, and it's transapical now. So that's the problem for tendine, and it's been there. People have been using, and it probably works very well. But since it's transapical, it's not likely to be popular because we need something transcatheter, right, to reduce the overall morbidity mortality. But the select patients who are, say, uh, 85 in Western world and above 70 in India, who are considered old, it may be a good option, but it cannot be option for rheumatic at all.
Okay. And as far as secondary MR is concerned, I think there is a discussion about coapt physiology or coapt phenotype versus the
Yes,
Mitra FR phenotype. I think Mitra FR
correct.
was the trial which failed. So,
Failed.
sir, what I feel is that it's like a spectrum. So, if we wait for too long, the LV might dilate, or some people might transition very quickly from one to the other. So, what is the sweet spot, or when is the time in the natural history of maybe DCM when
Yeah.
we should start thinking? Because too early might be that the patient might not be very symptomatic from that MR.
Yes. No, I
So,
think it's a very good question. Good question. But I think whenever it comes to all the treatment, it's hello, can you hear me? Yeah. Yeah.
yes, yes, yes.
Yeah. Sorry, I just lost this. Yeah. So whenever, yeah, in the sense, this is a common problem for every disease, whether it is mitral regurgitation, aortic stenosis. It's a common problem for every disease. But just to, be a little more pragmatic here, is that we cannot treat for future. We have to treat for present. So I think it is meant for symptomatic patient. That is the first thing. We do have a lot of MRs who are not symptomatic. They should be left alone as of now, because the biggest problem with this therapy is the longevity is something which we don't know. Now, most of these trial would look at 5 years, but when you put it for a 35-year-old person with a DCM MR, we don't know what happens 15, 20 years. We really don't know that part of this, and whether at some point we are actually, committing them to a future surgery. Even that happens in Western world. But right now, if the patient is symptomatic and on the maximum therapy, and if they have secondary MR, I think this is the way forward. But as you rightly said, if their LV systolic dimension is less than 70 and if the PA pressure is less than 70, that is the co-op subgroup, and they are likely to do well in trial. But I would even offer it to the others if there is, explaining them well. Because, I told you about a subgroup of one of my patient who probably needs it because there's absolutely nothing else. He's 60, 65, reasonably well preserved. Otherwise, single problem is heart, and there is recurrent admission. So, but LV is dilated. I have explained to him, and I feel because he's not even a candidate for a transplant. Otherwise, transplant would have been better for him. I would offer it to this patient. One more group of patient, I think, which we should all look at, which I see it in my center a lot, is the people who are on hemodialysis. We have a very, a nephro department which is very active, and there are a lot of patients on hemodialysis. There are 4 shifts. They work on 4 shifts. Some of them have dilated cardiomyopathy, non-ischemic, and a severe MR. These people are centrally wet. That means the frequency of dialysis is increased because they have pulmonary edema, but peripherally they're completely dry. Their dry weight is fine. They don't have edema. So and just for MR, their frequency is now increasing. They may be one of the ideal candidates for this therapy. And if they need transplant, I think it's better if they undergo this and then undergo transplant. Overall peri-transplant the outcome will be better. This is a sizable population. If you have a good nephro department, this is a sizable population.
Because even in COAPT 5-year, I think the mortality even in the Mitra clip group was not that low. I think it was 56% versus 70%, 5-year mortality,
Yes,
which is quite
exactly.
high.
Yes.
So very sick population.
Correct.
Yes.
So every patient needs GA. So like in LA, Dexmed doesn't work. In LA, how to
It does work. It does work, but you're there for 3 to 4 hours. So that's the problem here. So most people are comfortable with GA because of just the longevity, and you can manage the hemodynamic well. And also there is a step where you actually have to stop the breath. When you take the valve in, when you grasp it, you don't want zero breath. That is why the GA, but it's not a must. It's not a must. I'm sure in Germany they're already doing it in, they do everything under local and
Conscious
vocal,
sedation.
this one, a conscious sedation. They do everything. Americans do everything under GA, whatever it is. So this is where we are. We are in middle. But yes, the cases which were done under GA because just it could take 3 to 4 hours. You need to keep your day off, and you can't be doing more than one a day.
right, sir. So any more questions
And
from
few
our
great points were raised. One is about the durability.
Yeah.
Yeah, I don't know if I'm audible. Am I?
Yes,
Yeah,
sir.
you are, Dr. J. Yes.
Yeah. So 2 things. One is about the durability of the procedure. It's always a question mark as to how durable and how long this is going to last, especially in a hospital like mine where transplant is a very, very real option. So, and the cost of the procedure is such that the transplant, 10 lakhs more, you can get a transplant done. And so we'll always evaluate patients for both and wherever possible because we have a very, very active transplant group. And second thing, yeah, that is one point I wanted to make about transplantation. So, like you said, if there's a 35-year-old patient, we'll always evaluate him for a transplant first because that can become a destination therapy and it gives him near life. Whereas a successful microclip at best will give him symptomatic relief, but not so much difference in mortality. It will make a difference to his symptoms, but we don't know whether it is going to make a difference to the mortality in the long term, even out to 5 years. I think that's what the trials have shown, isn't it? You would agree, Dr. Ranjan?
Yeah, I think so. I mean, the COP clearly showed that the outcome with the mortality also there was a benefit. But as I think Satuja actually explained, it's a very high risk population. Mean age is always higher than our population's mean age, I think yes, transplant is a real option. But I think there's a sizable patient who just can't undergo transplant, for a lot of other
And yeah,
reasons.
absolutely. No, no, there is no controversy for those for whom there is no other treatment option
Yeah,
at all.
no other
This is
treatment.
just for the group of patients where transplant is an option. I think that should be
Yes,
exercised. But
exactly.
otherwise, it
Yes.
was really very.
So do you think the results can be extrapolated to the right side also?
Yeah,
Uh,
I feel, I mean, if it's just a feeling and this one, I think it will be much better for a right side than for a left side. Simply because, what other option we have, if you look at right side, when there is a severe TR
yes.
and this one, it's actually the trick well is not a solution for a right side problem, and cardiac cirrhosis is a real problem. So I think it could work better for right side. And tricuspid repair and replacement, the mortality is 37%. No, it's one third. That's much, much higher than even for mitral. So I think for right side, we should actively consider it. And procedural success also is higher. Now we have to use the mitral, but soon there is going to be a specific tricuspid because you're not doing a septal puncture. It is whatever you do, it goes to RV, right? But so procedural success is higher, and I'm sure for right side it should be more preferred, but it has to be isolated right pathology, which is not that common.
So is there a possibility that when you take the person off GA, the gradient across the mitral valve can increase uh, compared to when on GA?
I think, mitral should be okay. There should not be a major this one in mitral, whether it is GA or no, because, increased BP, MR could increase slightly. By thereby gradient could increase, but otherwise it should be okay. In the sense you're worried about LA to LV gradient, like the MS
Yes, sir.
component of it.
MS.
See, there are multiple ways you assess. You also look at the orifice itself. So if the orifice, it's not done for people with a small orifice in the first place. The orifice itself is big and we assess it. That's something which is assessed. So post GA probably because it's just between LA and LV, right? So it should be okay. It shouldn't really rise post GA. Tachycardia could rise it, but otherwise should be okay.
Okay. So any comments from Dr. Ratheesh or Dr. Rahul, maybe,
Great
or
talk.
anybody from the
Great talk. So just want to know what will happen if the clip embolizes, and
Yeah,
if
yeah.
SLD, if there is SLD, and when to put the second clip, and what are the
Yeah,
criteria?
yeah, yeah. This is a good question. If you look at the trial, clip embolization was not common at all. That is one. It's a small clip, so complications, as I keep telling you, is much lesser. So it will be in the arterial system. If you can remove it, you should remove it. If not, it should be, unless it goes to carotid, it should be okay wherever it is. It's a small clip. Then second clip, yes, you put the first clip and you realize that you are more than grade 2 MR and you realize that LA pressure is not really come down. That's when you put the second clip. It's put more medial to the first clip. But luckily with GT3, this was very common. Now the clips are bigger, GT4. So like two clip was a rule when GT3 was used. With GT4, it's almost always one clip. So, the second clip is hardly ever needed, especially for functional MR.
Can we put medially or laterally, sir? Putting clip in medially must be difficult than
Yeah.
laterally. So first
Um,
clip, say put somewhere in the middle or medial, and then second one.
second goes on the other side. Yeah, on the other side. Yeah.
Single leaflet detachment. What can be done? Nothing much.
Yeah, if the distance is too much, nothing can be done. If it is, yeah, even for a flail, it can be used provided the flail leaflets are near each other. Yeah. So pre-assessment is a must, but most of them with GT4 is possible to be done. And now if you want, you can release them one by one. The graspers can be released one by one. You can hold one part and then you can reassess, you can readjust. So a lot of more, further options are now available, and it's now open. Initially they were restricting it to some center only. Now it is open, and you have industry proctors who are actually quite good in guiding. So the procedure. I think the key is to have good imaging, which is the 3D imaging. So you need to have one more person who's extremely good in imaging. Should be able to show you what you want to see. That's the key. You're on mute.
Dr. Mukesh, would you like to ask anything, or anybody from our participant side?
It was very nice presentation. Ranjan sir, I just want to ask, in patients who are on dialysis and having severe MR and relatively normal ejection fraction, in those patients, it is the renal transplant. Do you think renal transplant will benefit the MR also, or we need to address the MR first and then go for transplant, renal
Transplant, I think if they're normal coronary, right? These are one with the normal coronary and the MR, right?
transplant?
So I think it is safer for them to fix their MR using a clip and then undergo the transplant, because the things go up and down in renal transplant. The fluid management becomes extremely difficult, and to clear a transplant in a high risk with a related donor giving a kidney sometimes becomes difficult. It's not just one person, it is a whole family. And as the key thing which comes out of Mitra clip is the safety. It's quite a safe procedure. The complications are much lesser than most of the intervention. So it's reasonable to offer clip as a first option and then make them undergo. If the LV is poor, there's a good chance LV recovers. If it is non-ischemic, if it is just uremic cardiomyopathy, there's a good chance it recovers. But that's okay because you're not subjecting them to a surgery. You're actually only putting a clip. So if they are financially okay, I think clip is a good option to do. Doesn't waste their time, can be done. You're only taking a venous axis, so it's easy to do it.
Okay, right. Sir.
Sir, any chances of cost coming down? Some Indian, or because you must be knowing about
Yeah.
models.
There is I jokingly call it my clip because like my well, which is going to which is definitely going to come. It's definitely going to come because somehow they always have access to advanced technology. So it's definitely going to come, and it's going to be at much lesser cost. And also, Pascal, no? Pascal is could come anytime for all we know, because now it's a single um, uh, company which has the cost is actually quite high. But they give 3 clips as for the price of that. So, it's a set of 3. So whether you use 1 or 2 clip, it doesn't matter. It's set of 3 which is given. Yeah.
Right, sir. So, if there are no more questions, I think, Dr. Swami, sir, if
No, I think we had a wonderful session.
Yes.
I don't know if I'm audible, but
Yes.
I think we had a wonderful session. Thanks, Dr. Ranjan,
Yes.
for
Yes.
making such a difficult topic so easy. As you said, just break it up into bits, and your talk was just like that. We broke it up into bits and followed you from one end to the other. I think
Yeah.
it's just the beginning. This technology probably, although we'd like to use it, much more frequently, the cost and the other issues make it not so easily accessible to everybody. But it's important to have as an option for a patient who is selected well with respect to anatomy and other social considerations. And if that happens, I think we can definitely offer good symptomatic relief and some quality of life to our patients. And Dr. Ranjan has summarized it very, very well, both the indications, the techniques, and the short term and the long term outcomes. I mean, I think there's nothing more to add. And thank him for such a nice session, and thank everybody in the audience for a patient hearing. And any questions, I looked in the chat box, I didn't find anything. and we should
Yes,
probably
sir.
have a follow-up session sometime soon
Yes,
where you
sir.
can present
Absolutely.
your
So,
experience with how
yes.
many you have done. And
So this will be
so
there.
if that's
We'll
it, I
be
think we can.
as is usual. We'll be. Yes, sir.
Yeah.
So this will be going on YouTube also. So it's there for everybody. And hopefully we will have some follow-up, as you rightly said, sir. Maybe we can have some follow-up on the Mitra clip as experience grows and interest also grows. So,
Yeah.
sir, with the permission of senior sir, I think we can close the session now and thank Dr. Ranjan Shetty, sir, for a wonderful elucidation of this new technology or relatively new technology. Thank you so much, sir. Thank you. And I think with your
Right.
permission, we can close the session now. Thank you so much.
Thank
Thank
you.
you.
And
Bye.
see you in
Thank
India
for
Live
the
and
opportunity.
Raipur also.
Thank you.
Yes,
Good night.
yes.
Thank you,
We'll
sir.
catch up. Bye.
Yeah.
Thank
Good
you,
night.
Ranjan
Night,
sir.
Ratheesh. Night, Rahul. Night, Mukesh.
Thank you, sir.
Night,
Night,
Saujatya.
sir.
Thank
Good
you.
night, sir.
Night.
Bye.
Bye. Bye-bye.
Dada,
Night,
Ratheesh
Ratheesh.
sir,
God bless. Bye-bye.
how are
बहुत
you?
जल्दी आ गया तू
नहीं सर, आज कॉल था इसीलिए. The long time. Where are you, sir? Lost.
अभी तो दिल्ली.
Oh, you will be there in the India Live.
Come someday.
नहीं मिलेंगे. और sir,
All well. You where you
all
now?
good. So I shifted to Dubai. It's my 3rd year here.
Great. Very nice.
Yeah.
comfortable.
हाँ होगा sir. I'm coming for India Live. I have 2 cases. I'm coming for India Live.
Great. तो मिलते हैं फिर.
Sure,
Delhi.
पक्का sir.
Delhi
पक्का.
also.
I'll come for 2 days and I'll meet you for sure.
Absolutely.
I have to meet Saujatya sir also. Saujatya 2.0.
सही है. ओके चलो मिलते हैं. ओके
Okay,
गुड
sir.
नाइट.
Bye. Good night, sir.
Bye
Nice
bye
seeing you all.
bye
Thank
bye.
you. Thank you.
Thank you. Thanks for joining. Yeah.
Thank you, sir.